Take care, huh?
Oh, Mary moderator.
Ma'am, we are live now. You can start the program. Thank you.
Yes.
Sangita, Mary moderator.
Dr. Srilekha Joshi is there, but I think
Srilekha ma'am has joined.
Dr. Anuradha, we will just first keep 1 minute silent for the just giving attendance to our this respected sir, huh? And after that we will start the program. Okay. Thank you, Dr. Asha madam, for reminding this thing. So always seniors are there to help us and guide us. So you are one of the senior who can just guide such things.
It is she,
Yes.
Dr. Satyagupta. She was the IAP president in 1980.
Oh,
and she was the head of the Department of Pediatrics in Maulana Azad Medical College.
okay.
The first woman who wrote the textbook of pediatrics. There was no textbook of pediatrics at all then. So she wrote that, and she was a very close friend of my father.
Okay, got it. Sir.
It is she. And she was a spinster. She's brought out a wonderful book on pediatric atlas and all that. I sent a mermaid picture and she acknowledged. Wonderful human being.
Got it. Gyani madam, if suppose your moderator is not here, Dr. Anuradha will take care. And actually the whole talk you have
I think Srilekha has just joined. Srilekha is here.
Yeah, okay, then
Srilekha.
it's good. Yeah.
I am here.
Thank you. It's 3 p.m. We can start. Dr. Anuradha.
Good afternoon on this platform for the 4th episode of Tet by legendary speaker. On behalf of WPF, I welcome all of you in today's session. Before starting actual session, I will request all the audience and our faculties to keep silence, to maintain silence. IAP President, Dr. Satya Gupta ma'am. Om Shanti. Om Shanti. Thank you so much. May God give place to the departed soul in the heaven. And now we are starting our today's proper program. The topic of today's TET session is triaging and life support for children. ACLS and BLS main focuses. And with due permission from our chairperson, Dr. Sangita Lodha ma'am, shall we start today's session, ma'am?
Yes.
We all know triage is a process of rapidly screening sick children soon after their arrival in the hospital in order to identify those with emergency signs, those requiring immediate emergency treatment. It is derived from the French word triage, which means to sort. The aim of the triage is to prioritize the patient care and initiate diagnostic and therapeutic measures as appropriate. It helps in rational allocation of the limited resources when demand exceeds availability. BLS for children and infants also focuses on doing several tasks, including chest compression, managing the airways, delivering rescue breaths, using AEDs, all as a team. By coordinated efforts, a team of rescuers can save valuable seconds when time lost equals to damage to the heart and the brain. There are many similarities and dissimilarities children, that is less than 1 month to 2 years, and 1 to 12 years. Children's Life Support Pulse is course for Heart Association for the heart healthcare providers who take care of the children and infants in emergency room, critical care, and ICUs in the hospital. This course teaches healthcare providers how to assess injured and sick children and recognize and treat respiratory distress, shock, cardiac arrest, arrhythmias, etc. To discuss this topic, we have a speaker, legendary speaker, who is then itself the zonal coordinator of ALS and BLS, Dr. Piali Bhattacharya ma'am. She is legendary speaker and who is not only BLS and ACLS trainer since long time, but also served as a zonal coordinator for the same in 2022 and 23, and also the joint zonal coordinator center zone in 2021. Besides being the prestigious post of VP of Center Zone CIAP 2023. And to conduct today's session, we are having a brilliant moderator, Dr. Srilekha Joshi ma'am. I must introduce her. She is consultant pediatrician at Indore, and she is currently the CIAP executive member 24. And she is moderator of today's session. She is having a interest in pediatric nutrition, vaccinology, infectious disease, social pediatrics with more than 30 years of experience. She has been secretary of Indore Academy of Pediatrics and president too, 2 years back. She is awarded by MP government for services in the COVID area and by IMA and various other organizations. With this, I hand over to Dr. Srilekha ma'am for moderating today's session and introducing our speaker, Dr. Piali Bhattacharya ma'am. Dr. Srilekha ma'am, please.
Thank you, Anuradha. Good afternoon and namaskar to all the respected dignitaries and my dear friends. It has been long time that I could not join our forum, as there was most of the time there was clash of the date or time of, between our activities and Central IP's activity. And today I am so happy that I am here in my own forum with all my dear friends. It's my real pleasure and privilege to introduce and welcome my friend, my mentor, an efficient, energetic, enthusiastic personality, a dedicated, determined, and dynamic leader, eminent teacher, stalwart of IIP, and above all, a simple, honest, and very good human being who is none other than Dr. Piali Bhattacharya. So Dr. Piali Bhattacharya, welcome in this session on behalf of Women Pediatrician Forum. As Anuradha has given her introduction, and we all know there is no introduction is required for madam, but as it is just customary, I'm just giving that madam is consultant pediatrician attached to Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She has been honored with various prestigious posts in IIP, like she was EB member in 2017 and 18 from Uttar Pradesh. She was president of Uttar Pradesh Academy of Pediatrics 2019. She was joint zonal coordinator of IIP ALS Central Zone 2021 and coordinator of IIP ALS in 2022 and 2023. She has been EB Central Zone IIP Adolescent Academy in 2022 and 2023. She was Joint Secretary, Indian Society of Perinatal and Reproductive Biology in 2022 and Vice President, Central IIP, Central Zone 2023. She has been chairperson of AEFI Committee on Immunization, Vishakha Committee on Sexual Harassment. She has been technical expert on maternal and child malnutrition, UP. Then she was member of editorial board, Indian Journal of Child Health. She was member, nodal person and technical expert on childhood malnutrition in UP state. And she was committee member of IIP guidelines for parental, for IIP parenting guidelines, as well as IIP guidelines on management of suicidal behavior. She has been awarded.
Srilekha, bas kare.
Yes, yes. And she has been awarded so many oration and so many things, and she has got national and international publication to her credit. So I welcome such a dynamic, gigantic personality, Dr. Piyali Bhattacharya. And before that, as we all know that in post-COVID era, we all hear about sudden collapse of a person, and that too very young persons. Here, there, everywhere, wherever we go, or we travel, or we just visit some places. So we'll just hear that there is sudden collapse, and not a time was not available to revive them. So there is need of the hour is that each and every member of the society should know this ALS and BLS. And we are so fortunate that being from medical fraternity, we have been trained in BLS and ALS right from our undergraduate and postgraduate period. But still, it's very essential to just refresh our knowledge, to relearn the skills, and to retrain ourselves so that we can just propagate or disseminate this knowledge in the community. And as we learn all these things, this will help us to keep pace with the recent advances as well as optimizing the result of CPR. And it will bring the best of the best outcome whenever we are exposed to doing this ALS and BLS. So with these words, I just request Madam to conduct the session on ALS and BLS.
Just I
Thank you.
request 1 minute, Dr. Himabindu Singh, to give welcome address to the audience also, because now I can see Dr. Himabindu, who is a past Women Pediatricians Forum chair. I request Himabindu madam, just give 1 minute welcome address to all the audience, and then we will start the session.
Thank you.
Kelly, ma'am.
Thank you, dear Sangita, my friend, and what should I say, soul of WPF, and all the stalwarts and our Pyari Piali. The other day I was calling her. We're all connected, we are bonded, and we will be together. And I'm sure we'll be missing some of us in different, because some of us may be busy at certain times of time. It's okay. We all can come back again and connect, no problem. And we should really highlight this sessions. And as our women pediatricians, many of us are doing so much work, both in the community and also in the academic fields, in different chapters and sub-chapters. They are big experts are there. We should highlight, and I really should thank Dr. Sangita to bring this series of Teat at Teat with legendary speakers. That's really so nice. And I'm so happy that Dr. Piali is our speaker today, and we recognize her. She has done so much work in IAP. Salutations to you, Piali. And we all should, we can motivate our younger members who can still, in spite of all the challenges what we face, we can still do so much for IAP and for children. So with this few note, I welcome all the include Srilekha. We really missed you, but I'm so happy that you're back on the forum. And all the delegates who are joining us today, we heartily welcome you on behalf of the Women's Pediatrics Forum. It's a very unique forum with a lot of programs Dr. Sangita is planning, and we already had a rocking time till now. I'm sure this will go ahead, and we'll be seeing more and more programs in future. So while welcoming all of you once again, I hand over the stage maybe to Sangita to invite
Dr.
Piali
Piali
once
Bhattacharya.
again. Piali, over to you.
Thank you, Hima. Thank you so much. So for all my friends out here, it is actually this whole thing about ALS, BLS. It is actually see, it's an on hands kind of a thing, but I have tried to make you understand through a pictorial approach. So I hope you people will be able to identify with me how things are actually being done. And I hope almost all of you will have done the course of ALS or BLS at least. And this is just going to be a little refresher. Everybody is welcome to ask questions in the chat box. And or else when I finish, you can also raise your hands. If you are unclear about something, please note it down. And Dr. Srilekha, I'm fortunate to have her, will actually look into the matters. After saying that, let me sort it out, because triaging means sorting out. So sorting out in children, I will just show you this newspaper cutting where a boy dies inside a classroom. And today we have the family members claiming that the teachers didn't do anything to save Shakti. And for 45 minutes, the child lay on the bench. And after that, when he was taken to Babu Jagjivan Ram Hospital, the child had already gone. We had lost the child. Why are we saying, why have I put up this? Because when we did a statistics survey, less than 2%, are aware of the CPR procedures. And in India, I would say 5 to 6 lakh people are dying due to sudden cardiac arrest, more so now in the post-COVID era, as already pointed out. Now, if you understand what resuscitation is, if you can help a patient who collapses, an early resuscitation done within a few minutes of fall can give a result of a 60% survival, because most of these arrests are outside home. So you need to train others how to do the CPR. And then you have two very good numbers. I have personally tried them. 108, the ambulance comes first, and 112, you can always have help from there as well. So we have help at hand. So we should understand the chain of survival. There are 5 links to adult as well as to children's survival. Firstly, you should recognize the cardiac arrest. So when do you say the cardiac arrest has occurred? Then you are not God, so you will need help. So if you need help, then you must activate some emergency response system. And I said there are 2 numbers, 112 or 108. And if you have your mobile and you're nearby somewhere or a hospital, you can ask your emergency people also to come and help and get an AED. Next is early CPR. Basically, the meaning of CPR is what? Meaning is that we act as a surrogate heart. So we are basically doing the heart's job and pumping blood everywhere to the vital organs, perfusing them and keeping them alive. And then onwards, if the heart stops, if we cannot maintain the cardiac activity, then an early defibrillation. And you must have seen AEDs everywhere, in a railway station, in an airport. You must have seen these AEDs, which will be of great help. And if it is a hospital setting, then of course we all have defibrillators in the emergency. Now, do we leave the patient over here only? No, the chain of survival also has another step. That is a post-cardiac arrest or return of spontaneous circulation, as they say, ROSC, and then to restore the quality of life. You need the child to be up and about, so you cannot just let the child be after just resuscitating. Now, these are some case scenarios, and I've put the photographs at the bottom. Case number 1, where the child has URTI with mild fever. She's waiting for a turn in the OPD. Then the number 2, there's a crying child in the OPD, but there's something there wrong because that attracts your attention. Then there's a 6-year-old child. She was having an episode of seizure. You can see her lying with eyes wide open. However, when she's reached the pediatric emergency, the seizures have stopped. And last but not the least, this is a child which has been fished out of a pond, and the mother rushes to your chamber with this unresponsive, not breathing baby. Now, as I've said, we are dealing with triaging. Now, which one will you attend first? Obviously, if you have triaged, you will triage and treat the sick baby first. So that is the importance of evaluating these babies, of identifying the severity and the types, and thereafter intervening. So if you've evaluated, there are several steps in evaluation. An initial impression, we will talk about all this. This is a summary of what you do. Identify where it is, what the type of insufficiency is, how much of severity it encompasses, and then you intervene accordingly. And at each step, you reassess, EII or evaluate, identify, and intervene. So when we talk about basic life support, everybody has explained that it defines a sequence of events after a pulmonary or cardiac arrest, and BLS does not include the use of any drugs, any invasive skills. So it's just a non-hands procedure. Without anything, you can do a BLS. Now, CPR. CPR, how do you assess who will need a CPR? So most children, you have to understand, this is not like the adults. The children cardiac arrest is usually secondary to respiratory arrest. ऐसा नहीं होता है कि children में primary cardiac arrest हो जाए. अगर primary cardiac arrest हुआ है, that means that the child has some cardiac anomaly, something wrong in the heart already in the rhythm or in the cardiac structure. So that is why there's, and that is a very little percentage. So you need to prevent a respiratory failure, a respiratory arrest, so that there is no cardiac arrest thereafter. Now, when you recognize CPR, whom to give, then you need to have look, listen, and feel approach. What do you look for? You look for responsiveness. What do you listen to? You listen with your ears to the breathing. And what do you feel? You feel the carotid pulse in older children and the brachial pulse in younger children. So, look, listen, feel approach will tell you who needs CPR. And what are the steps to CPR? First and foremost, assess scene safety, determine the responsiveness of the child, check the carotid pulse, perform the chest compressions, open the airway, and check breathing and deliver breath. So this is the summary of the steps involved. So assessing the scene safety. I mean, if the house is burning, you won't jump into the house. Or if the child is drowning and you don't know swimming, you won't jump into the pond. Similarly, so if there is anything wrong going on, so you first have to assess that the scene is safe, or the child has been hit and is in the middle of the road. You have to check whether the scene is safe or not. And of course, you have to call 111, 108, wherever if the responsiveness has been found that it is not there, there is something wrong, you need to look for help. So once you have assessed the responsiveness by look, listen, and feel, you say, are you all right? You don't actually bang the child on the shoulders. You just lightly tap on the shoulders and you ask, are you all right? So you find that the child is not responsive. And then you go ahead and check the circulation. Checking the carotid, you can put your hand in the middle of your throat and sink back into the groove beneath on your side. So check the carotid pulse within 5 to 10 seconds. Do not go for more than 10 seconds because that again you are delaying circulation, delaying the CPR. And it has been found that every minute that you delay CPR, there is an increase of mortality by 17% in a child. So please do not delay. Please do not keep checking for pulse all the time. Now you've shouted for help, check scene safety. If there is no pulse or if it is abnormal, then what are you doing? You are actually starting CPR. Supposing there's a cardiac arrest, supposing there's a respiratory arrest, supposing there's a combination of both. So you have now started a CPR. Okay. So CPR means what? CPR means a circulation, airway, breathing through a CAB approach. CAB approach means compressions start first. It used to be airway ABC. Now we have surveys, the statistics have all shown that you should not delay the compressions. And of course, the ALS has come out with the CAB approach instead of an ABC approach. So compressions first, airways to be maintained, and then of course the breathing part of it needs to be looked into. You need to give breaths. So, but where do you compress? So compression point, intermammary line is traced, and on the sternum, at the intermammary line or just below the intermammary line, you place the heel of your hand. So the heel only touches the skin of the child. Do not put the full hand on it. And then you hold the heel of the hand on the chest and you actually are holding the other hand. The dominant hand is on the chest, the heel hand, and then you're holding the other fingers with the other hand, non-dominant hand. Now push hard, push fast. So 1, 2, 3, 4, 5, 6. You continue and you chant like the mantras till 30 chest compressions have been delivered. But remember, how do you apply the compressions? You can look over here and see that the hands are straight. The person is kneeling beside the victim And of course, he's looking at the chest. So this push is coming from the shoulders and not from the hands. So you are delivering 30 compressions initially at the rate of 100 to 120 compressions per minute. You need to practice all of it. And what? You are allowing the chest to recoil back fully with each compression. So as you compress, you have to allow it to recoil. Without raising your heel of the hand, you allow it to recoil. So push hard, push fast at the rate of 100 to 120 compression, and the push comes from where? From your shoulders. So after the initial 30 compressions, assess and establish the airway. So you have to give 2 breaths now. Now, if it is an older child, then a child rather, then what do? For the child, you have to cover both the nostril and the mouth with your mouth and deliver the breath. For an adult, you pinch the nose and you deliver the breath to the mouth. So 2 rescue breaths are given over here, and the maneuvers of keeping the airways open is by head tilt and chin lift maneuver, or you have to give a jaw thrust maneuver if you suspect that there could be a roadside spinal injury. So in that case, you will not move the spinal column too much, or you will add on to the injury to the spinal cord. So these 2 methods can be used to open the airways and deliver the breath. So the dictum is, do not push too fast, do not push too hard, but push hard and push fast. So there's a rate and rhythm which needs to be practiced. And do not be, in any case, do not be a rocker, a bouncer, a bender, a double crosser, a massager, or a sitter. So these are the positions which you will have to avoid so that you give effective CPR. Because if you do this, then you will not be able to push to the right depths of about a 5 centimeter inside the chest cavity. So the strength comes from the shoulder. If your hands are bending, if you are just bouncing or rocking or just sitting and trying to do it, you will not be able to deliver the compression at the right rate and at the right depth. So you have to be a perfect one when you do a CPR. Now, once you have done 5 cycles of CPR, you have to see whether you've given a rescue breath, you've done a CPR 5 times, and then you have to check whether you need to still continue give rescue breathing, or somebody has arrived with a bag and mask, or you need to do something more, or you need in endotracheal tube, or time has come to shift the child to the hospital. So the bag and mask, as you all know, is held in the EC technique, and then breaths are given through the mask thereafter. Now, if you have done everything and somebody has arrived to help you with the AED or the automated external defibrillator, then use it as soon as it is available, because AED will be able to recognize which rhythms are shockable and which rhythms are not shockable. It's a small portable device, so you can use it outdoor, you can use it anywhere and deliver shock. So once you have attached the leads, one infraclavicular and one near the apex of the heart, the AED will start reading the rhythm. So if you are doing a CPR, you will have to stop at that point when the AED recognizes the rhythm and tells you that this is the shockable rhythm or non-shockable rhythm. So the computer AI will tell you shockable rhythm, please stop. And then it will ask you to remove yourself from the spot. So what will you do? You will say, I'm clear. All of you are clear. I'm clear, you are clear. And if you have by chance applied oxygen, then oxygen clear. And as soon as you are clear, the AED has delivered shock and said shock delivered. So now you can again go back to CPR. And the CPR is 30:2 universally. And this is the point of time when the AED is doing all that check, rhythm check, delivering the shock. What do? You change places, because one person only doing a CPR is nerve-wracking, absolutely. You are alarmed whether you'll be able to save or not. So there's a mental and psychological pressure, and there's a tremendous physical pressure when you are trying to push hard and push fast. So, for children, if you have a single rescuer, it is 15:2. Otherwise, it is 30:2. For infants, it is the thumb encircling technique and not this technique that I have shown over here. So you switch roles when the AED is assessing, and once the breathing has come back, you have some semblance of normality. The pulse is all right. The pulse is all right. What do you do now? You actually roll over the patient. So this is called in the rescue position. So you can see the first position over here, where at the right arm is now at right angles. Right arm, right angles. Thereafter, what do? You push the left arm to the cheek, the palm to cheek position. And thereafter, what do? You actually fold the knee over here, and at the go of 1, 2, 3, you turn the person. So you have now reached the rescue position. This is the rescue position, which is the most comfortable position for a victim. Now there were changes, and as already Anuradha has said, this is basically a science, and science changes. So when we did last in 2015, when we did the CPR, it used to tell us that rescue breathing has to be given every 3 to 5 seconds. That's around 12 to 20 breaths per minute until spontaneous breathing has come back. But when the 2020 updates came, in 2021, it became lesser. From 3 to 5, it became 2 to 3. And the ventilation rate CPR also, during CPR also with an advanced airway, if you have ETT in also, it reduced to 2 to 3 seconds. The rationale that was given is that if the ROSC, or the return after spontaneous circulation, that is much better in children if you do an early breath rather than delaying breath or delaying time. So at least you must give every 2 to 3 seconds one breath for 1 second. So that is what the target is, 20 to 30 breaths per minute in both situations. If you have an ETT, if you don't have an ETT as well. So this is what the change came. And so when the changes came, we actually skipped that. Now the 2025 changes are going to come. Every 5 years, the science of ALS and BLS changes. So when we talk about triaging, again, it is evaluate, identify, and intervene, as I said. So we have 4 parts: the initial impression, the primary assessment, the secondary assessment. So when you do the initial impression, there are 3 components. It's a handoff procedure. You do it visually and auditory. I said look, listen, and feel. So this is the part that is look, listen, and feel. Takes seconds. The moment the child has entered your OPD, you can recognize, look, listen, and feel. So what you do in that, we will be talking about that. Primary assessment. Now that is a hands-on assessment, and you have 5 components: A, B, C, D, E. We will talk about that. And at this point is where we attach the oximeters, we attach the defibrillators, we do a blood glucose test. Secondary assessment. What is very important is taking a sample history, which we do not do. Please, if you can implement this in your OPD while taking a history, it would be very nice. You won't miss any point if you do a sample history. And of course, a head-to-toe examination. And post that, now we've not spoken about any labs, any diagnostics, only about a point-of-care blood sugar test. So initial impression, appearance or consciousness. We check whether the alert, agitated, lethargic, or unresponsiveness, and accordingly we have our actions. That is whether we start an oxygen, We do a blood sugar, we attach all the monitors and call for further help. Breathing, A, B, and C. Now breathing. Breathing, whether it is normal, whether it is fast, whether it's slow. And remember, slow breathing is more ominous if the child is grunting. It is more ominous than actually tachypnea. Now, color. Again, that is a very important part of initial doorstep assessment. If the child is looking pale, I mean, we have identified many a child at the doors. ये तो toxic लग रहा है, ये तो ठीक नहीं लग रहा है बच्चा. So that is what is initial impression. So now you come to a conclusion whether there is cardiopulmonary arrest or cardiac arrest, whether CPR is needed, or it is a life-threatening situation where acute care is needed, and you quickly gather a team and you start doing your process. And if the child is stable or not, like I said, which child in the OPD will you try and give BLS or ALS to? So then such children with an URTI, with a fever, you will proceed with further evaluation. So this is how you go ahead with initial impression. Primary assessment, of course, airways, I said if it is maintainable or if it is not maintainable. You have tried head tilt chin lift, you've tried jaw thrust, but whether you are being able to maintain it or not, if not, then whether maintainable with small adjuncts. So if they are maintainable with small adjuncts also will do. If not, then you need an advanced airway tube. So these are the adjuncts. I've put oropharyngeals, nasopharyngeals, LMAs, and some nasal prongs over here so that you understand that we need these adjuncts to make a maintainable airway. Now, breathing, when we do, the breathing rates, the cutoff rates I have mentioned in this chart. It is a very important thing that you have the cutouts of this in your OPD or in your resuscitation area so that you know actually what respiratory rate. जल्दी में याद नहीं रहता है कई बार. अरे 40 हो गया, अरे 50 हो गया. So remember that greater than 5 years it is 30. And 1 to 5 years, it is 40. 2 to 11 months, it is 50. And less than 2 months, it is 60. So you have to look at the rate. You have to look at the work of breathing. You have to look at the chest wall movements. You have to look at the air entry. So as I said, this is on hands and you have to attach a pulse ox. So you should know actually what is happening. So as I said, the first compensatory mechanism is tachypnea. The next step is increased work of breathing. A chest wall asymmetry will indicate if there is a chest wall problem, if there is a fracture, if there is a parenchymal disease, or if there is a pleural disease. And the problems of lung parenchyma and pleura are detected by auscultation only once you put the stent. Now, a simple pulse oximeter, which is now the fifth vital for us, is easily available and we can always check with the pulse ox. So, what is the correlation? If you have the upper respiratory, alanezi, suprasternal, supraclaviculars working, then it's upper respiratory. If you have the subcostals also working, sternals working, then it's a lower respiratory. And if it's a grunt, there is a lung parenchyma involvement. And the seesaw, you see these are late stages of tissue disease or peripheral ventilation failures. Sometimes also neurological issues may occur. What about the chest wall movement? So if there is a gurgling sound, so there are significant secretions in the upper airway. So however much you give oxygen, you are not able to send oxygen to the lungs. So you need suctioning over here. If there is a upper airway partial obstruction, what will we get? We'll get stridor. We'll get we may get wheeze. Or you might grunt. Or when you put the stethoscope, you will get crackles over there. So look for any asymmetric chest rise and auscultate to listen to these multiple sounds which will identify ki kahan par, where is the problem there. And then, of course, as I said, pulse ox, it will detect whether there is an oxygen saturation right or not. Sometimes, if the child is very, very anemic, you may not get a correct report, but most of the time, it is very, very helpful if the SpO2 is greater than 94%. And remember that if it is less than 90%, you may have additional interventions required. So once a stable target is reached, remember, adequate oxygen has been reached. So primary assessment now has circulation. A, you've done airway. B, you've done breathing, and now you come to circulation. Circulation may you do heart rates, peripheral and central pulses, you do a CRT, you do skin color and blood pressure. And remember that skin color and temperature should not be done in an AC room. It should be in a normal temperature of the daytime so that you can assess what the skin color and temperature actually is. And an additional thing which we need to do always is what? Urine output. Bache ne peshab kiya, and what we need to check, it is the sensorium of the child. So that will also give us information about what is the primary circulation of the child. So if you have a heart rate normal, what do? You proceed further. If you have it fast or slow, you apply a cardiac monitor to check what the rhythm could be. Or if you have an AED available, you check whether it is a shockable rhythm. And if it is absent, then of course you need to call for help and you need to do a CPR then and there only. Now, rhythm, we do whether it is a narrow QRS or a broad QRS. You see, we are pediatricians, we are not cardiologists. So, we don't do those fine-tuning things ki kitna usme hai, kitna centimeter, kitna kya. We don't classify all that. We just do a normal or narrow ORS, or a QRS or a broad QRS. So, once you've done that, you know the heart rates that will occur in these QRS complexes. You can deduct the heart rate from the ECG and accordingly you can proceed further. So what is the intervention then? You will refer to the charts, assess circulations. If it is greater than 220 in an infant, what you do? It could be an SVT. So you will use ice packs if the child is comfortable and arrange for other things then. Now, if it is greater than 180, you will do a cardioversion in children. And if the pulse is present again, you will do a broad complex with a cardioversion. You will do in a pulse which is present. However, if the pulse is absent, you go for a BLS algorithm. You start CPR immediately. See, now this is what if the pulses are there, if the pulses are absent, if there is decreased volume. Again, you will have to identify whether it is a shockable rhythm or not, and you have to have the IV access by this time. Now, skin color, you can have pale, you can have cyanosed, mottled, pale, and oxygen should be the cure for all this. Skin temperature, again, normal, etc. If there is fever, you have to treat fever by paracetamol. Of course, rule out hypothermia and hypoglycemia. And blood pressure, minimum acceptable, I'll just give you a chart. 1 to 10 years, 70 plus age plus into 2, and greater than 10 years, it is greater than 90 mm per mercury as per the age of the child. So, minimum acceptable. If it is, then you have to ask for help. So, how much time? It takes hardly minutes. So, you can train your team members to perform these steps if you have this chart available. And I've given you a ready reckoner, the blood pressures as per age, the fall of 10 millimeter of systolic blood pressure from the observed level is significant because initially you may not have a fall of blood pressure when the body is employing all the compensatory mechanisms. Afterwards, the blood pressure starts falling, and once it starts falling, you've had it. So identify shock as early as possible. Now, when you identify the shock, it is normotensive, hypotensive, hypovolemic. So what do? We usually give saline boluses. But if it is a distributive shock, remember, do not try to do too much of saline boluses. 10 ml per kg is sufficient once you've tried it and you've then found that no, this is a distributive shock. Please go ahead with inotropes. And restricted as I've said, restricted IV fluids only. And obstructive trauma or when the duct-dependent lesions, in that you have to treat pharmacologically. So disability. Now, this is one point where you have to see that in the OPD, in a busy OPD, we cannot do a GCS score. So we do AVPU. AVPU means if the child is alert, if the child is responsive to, hey, Munna, 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 you're calling, and the child is responsive to your voice. Or if the child is still not, then you pinch the child and he says in pain, he says yelps and he says, off, chodo. And otherwise, the child has not responded, unresponsive. So alert, voice responsive, pain responsive, or unresponsive. And they match the GCS codes also. So you can have a GCS score between 6 to 15. Remember, once it is 13, you have to be very vigilant. Pain responsive ho gaya, to problem hai. And at this stage, disability management mein, you have to do a point of care blood sugar as well. Remember to undress. I have missed a patient because I did not undress. The child was unresponsive. The child had been physically abused. And later on, when I opened up the child, there was a fracture in the shoulder. There were bruises at the back. So normally we do not look at these abused children. So open up and see these children and take care. If there is a roadside accident, then cervical spine injuries could be there. कुछ नहीं मिलेगा तो कोई गमछा मिलेगा, some towel मिलेगा. You can wrap it around the child's neck so that the neck is safe. And skin and core temperature may not be the same in children. So as I have said, you can do a GCS scoring, and exposure is also important. So again, you can train your team members to perform by a simple checklist. And you must identify whether it is respiratory distress or respiratory failure. Because if you do not identify distress and treat it, what happens is it goes into failure and becomes more difficult to be revived. So there will be cyanosis in failure, there will be poor responsiveness in failure, and worsening features of distress despite oxygenation in these children. So the difference is that for a distress, you can treat with oxygen, and for a failure, you will always need assisted ventilation. So within 2 minutes of arrival of a sick child, you have decided whether the child requires ventilation or does not require ventilation. That is the effect of triaging properly in a child. And secondary assessment, I will not go too much into details because it involves a assessment from the head to the toe. So from the scalp, from the eyes, ears, nose, mouth, the carotids, the jugulars, the lymph nodes. You need to go down again to the chest and hearts and lungs, and then down to the abdomen. You do the liver and the spleen, if any free fluid, if any borborygmy. And then you go down to the limbs also. Then turn the child around and go to the back and examine the back and spine as well. So focused head to toe examination. But this is very important that you do a focused history. What are the signs and symptoms? What are the allergies? Usually, if you are truthful to yourself, you never take a history of allergy in your OPD. And then the medications which have already been received. इतना टाइम नहीं है बिजी हॉस्पिटल मेडिकल कॉलेज के ओपीडी में कि 150 जगह वो देखा के आया है तो वी विल इन दी 100 पेशेंट्स वेटिंग हम सारा का पर्चा देखेंगे अरे जल्दी जल्दी बता दो क्या दवाई खा रहा है. So medication is very important, and past medical history, of course, if there are any comorbidities, like they were talking about the COVID times, we were especially careful whether there is a contact with the COVID patient or not, and past history of family members with COVID. Last meal taken, and when you are planning for procedure, for sedation, the stomach should be empty for 6 hours or so. So anesthetist will refuse even if you have to do a procedure. And events that brought the child to the ER. So you need to have a full comprehensive sample history. And then now you have identified what is the type and what is the severity. So whether it is an upper airway, lower airway, parenchymal lung disease, or a disordered control of breathing, whether it is a hypovolemic shock, distributive shock, obstructive shock, or a cardiogenic shock. And whether it is a distress versus failure, whether it is a compensated versus hypotensive shock. Why is it important? It is important because then you know how quickly to institute the therapy and what treatment will actually be needed. So you're aiming at the lungs, you're aiming at the heart. Where are you aiming at, or at something else? So you evaluate, identify, and intervene. Here is a chart which I have said as per severity, what your interventions should be. So oxygen is a drug, remember. Be safe when you are giving oxygen. So ET, intubation, LMA, or other accessories, vascular access, point of care blood sugars, isotonic bolus for fluids, and inotropes, some at hand, of course. So what are we looking at today? We are looking at 21st July. The IIP's first CPR day was celebrated after our learned Dr. Ananda Shandilya passed off, who was a doyen of ALS and BLS, one of the founder members. So each one should contribute in some way or the other. You need not be an instructor to spread the message. And all other national IIP days are already being established. IIP CPR Day is literally a new baby. It needs nurturing. So take home messages, take the right action, take it confidently, make a difference between life and death for a person dealing with a cardiac arrest. Save a life. Thank you so much. You see, it is very long, so I tried to make it concise. I hope I did not hurry too much.
No, ma'am. It was really very wonderful session. And if anybody is having any question answer, they can just put in the chat box, or
Srilekha?
Dr. Srilekha Joshi can take over the question answer session. Dr. Srilekha Joshi, are you there?
Unmute yourself, Srilekha.
Wonderful session, Piyali madam, as it always be. And you have made the complexities of CPR so simplified for us. And now I'm just seeing whether there are any questions in the chat. And meanwhile, if anybody wants to ask any question, they can go ahead. And I think, Dr. Sangita, we should decide what should be our role in future. How can we disseminate our knowledge? And as Madam has shown the slides, and we can simplify it for the lay people.
Yeah. I
In
think
Indore, we are doing it in schools, in communities, and as the police association, then for hospital staff and everywhere. So
I kept it pictorial. That is why, Srilekha, so the pictures will tell the story.
Yeah.
I do remember Dr. Swati Bhave madam, just when she just come to that Dr. Pyali is going to give this talk, she just shared with me, Sangita, in 2000, I just brought that mannequin from US, and I had started this session. So I told madam that I will definitely share that you had taken efforts that time in 2000, 24 years back, to brought the mannequins from US. And that was a very difficult task at that time, because I think Dr. Swati Bhave madam and Dr. I don't remember right now the name. Both have just worked hard to bring at least one mannequin to just teach the students and the pediatricians. And I think we should carry out this in our schools, colleges, and everywhere.
Yeah.
It's the preliminary, very, very preliminary instructions everybody should know. Any questions?
We have the mannequins in every zone. A lot of people in Indore also, Srilekha, you all also have, na?
Yeah,
so, people
Madam,
are going.
We are doing it on mannequins also. And we are using teddy bears also.
Oh, very nice.
Nice.
So, actually, when I was president, we did 51 activities in schools, and we did it in nursing homes for actually paramedical staff.
Very nice.
And after our this session only, there was 2 or 3 cases. In one of them, he collapsed in lift in Medicare hospital, and they were able to survive him.
Very
because
nice.
the liftman has learned it from during that session.
Very nice. Very nice.
And in school also we did it.
Same here. Our dermatologist was saved. He drowned in the swimming pool. He was fortunate that our anesthetist was also swimming. So they dragged him. The child was swimming. She saw. She said, "Ajit uncle, नीचे डूब गए हैं. लेटे क्यों हैं?" So he was lying on the floor of the pool. He was picked up, and the poolside resuscitation was done by the time the ambulance arrived. And I've seen his X-rays. They were totally opaque. Both lung में पानी घुस के, it was totally opaque. But he lives. He had been saved because of the early response. So if each of us can give an early response, it'll be very, very nice, you know. It'll be fantastic.
I had an experience at in the flight, you know, ma'am, when it was on the top. Yeah, one person get collapsed, and then everybody was just running. Any doctor is there in the flight, and then I just came, and then I did it, and he came out very well.
Very nice.
Just
Very nice.
wrote down the poem on that overall situation, ki how the things was going on, and he was just looking at me when he came out, and her wife was just hugging me like anything. You have saved my life and my husband life. So it's, I think, very necessary and mandatory to have this session with all, and everybody should know about this ARS and DSL. That's why I chosen this topic, because everybody is thinking we know about this, but through the horse's bite we can say it. I think it will be best.
The
Okay, we had
sequence
a
of
very
event is very necessary, and our reflexes should be that fast, and that we should be that alert. That is very essential, and that is
yes.
why we have to learn it from legendary teacher like Piali
I know.
madam.
We had a good audience, Srilekha. I think there were about 62 people here, and I hope I have percolated at least something into the mind's awareness.
yeah.
So
And
now
they
they
have
will
good-
go and ask their own zonal coordinators, bhai, humko bhi karao.
Yeah.
On hands.
Yeah, and madam,
Or,
we are having YouTube recording also, so we will float it everywhere, and even in our WPF website also, and the YouTube channel will just keep it throughout the year.
Yeah, and during CPR week, if each and every person who has attended this session, if they disseminate all these things in their own places, so that will be really fruitful and meaningful.
Yeah, sure.
So that
You can do it
Anuradha
for
can-
your own PG students. You can do it for the nurses.
Yeah.
You can do it for, I have done it for my sweepers also, you know,
Yeah.
in the hospital. I've collected them together. I've done it for them also.
Yeah.
So nobody is too less or too small. Please,
Yeah.
everybody, it's a sort of a prayer from my side. Please go ahead and do the training of, आपको कोई नहीं मिले तो आपका वार्ड में जो 5 नर्स है उसको ही पकड़ के करा दो, बट करा दो.
Yeah, and everybody is very important क्योंकि डॉक्टर को ढूंढने में तो it takes lot of time. जब वो collapse हुआ है तो at least they should do the initial things. So it's very necessary that they should know what is to be done.
हाँ, हमारे
That is our-
रिसेप्शनिस्ट को सिखाया हम.
सिखाया, yeah.
तो वहां पे दो एक
Same
जो
I
कोलैप्स
did
हुए हैं, they
here
started.
also, yeah. और attendants जो आते हैं उनको भी we can take small sessions in our own clinics also.
Hima wants to say something. Hima, unmute करिए.
Yeah. No, I was just saying that this is a social commitment, as we WPF is committed for social, awareness, and I think BLS is a good topic, and giving a breath, saving a life. This is what we keep on saying. But we should take active role among our trainers. Dr. Piali, how many are actually able to pursue for a long time? I think there's a burnt out little bit. These programs are very intense, especially on the women. They have to leave, I think, 2 days, especially for advanced and basic. So I think ek din mein ho jayega, but still to take out time and the commitment. I've seen myself over last. I was trained in 90s, and then I did for some time, and then even the young women are joining. They are after some time they are just leaving. Maybe they not able to give so much time. So I think if not a structured program a full day, just we can do as a social
Short
activity.
2-hour thing.
Short.
Yes.
Chota. Just is a question of spreading the knowledge. So I think we should be able to do, and we should encourage our women members and all the community IAPNs to do this at least in a shorter way. So shortcut method में जो basic things हैं बता के airway breathing circulation वो चीज हम कर सकते हैं community में.
Dr. Rekha Harish is here. Dr. Rekha,
Hello, Dr. Rekha, are you there?
a senior member, Dr. Rekha. I just saw her name.
Yes, she was-
Yeah, she's there. Unmute नहीं है, mute है.
So Should we wrap up since there
Yes,
are no
yes. Now it's the time
questions?
for, yes, ma'am. Vote of thanks.
Yes, ma'am.
Still 3 minutes are there. So, Dr. Anuradha, who is going to give us a vote of thanks today?
Dr.
Anuradha.
Mamta Bajaj, she's Associate Professor at JLN Medical College, Ajmer. She was my student few years back and now she's faculty at Government Medical College.
Wow.
Dr. Mamta Bajaj for vote of thanks.
Thank you so much, ma'am.
Before that, I think Dr. Madhu Raturi was want to say something, and then
Yes,
Madhu
Yeah.
madam is
Yeah.
here, na?
No, I'm just saying, well done, Piali. Everything all explained well and lovely sounds if you're making. So we enjoyed the session. And definitely, what am I saying? The short programs are always good. Sometimes very long programs, very difficult, especially to go around and do. And
Exactly.
definitely on 21st, we are going to take sessions in different clubs, taken at orphanage, many places. We'll be taking the program on 21st. But definitely it needs, and that wonderful song of CPR by Dr. We do play that. We have already taken few sessions also. Trained. Many people are trained. It's good. I think it's spreading. पहले तो लोगों को पता ही नहीं था ना, करते ही नहीं थे, मालूम तो था कि CPR होता है पर उसका स्टेप टेक्निक नहीं पता, बट अब कम से कम सोसाइटी में कहीं तो जा ही रहा है मैसेज, इवन इफ यू सेव वन लाइफ.
yes मैम, डे का भी अच्छा एडवर्टाइजमेंट होता है. CPR डे लास्ट 4-5 years से न्यूज़पेपर एंड मीडिया रेडियो एवरीथिंग इज कवरिंग.
स्कूल कॉलेजेस सभी जगह होना चाहिए जहाँ तक कर सके. Trying.
Yeah, सही
निर्मला
बोले
जोशी
madam.
मैम,
okay.
Nirmala
Now,
Joshi
one
ma'am, would
minute
you like
left,
to say?
and I think we should go for vote of thanks because we are very much strict to the time.
I
limit
want
time.
to say one thing. We are planning a school level programs of CPR after opening the schools, and we have talked to more than 5 or 6 schools. They are ready to do it, and it's a very important program in day-to-day practice also. So we are doing it for more than 10 class students. The principal has told us we will do it for more than 10 class
10th,
students.
11th, 12th.
Yeah. Yes, ma'am. So we are planning it in a large scale
Thanks.
in Lucknow.
I think we are
Very
rocking now. All the ladies pediatrician are just doing excellent job. And so
All
nice.
over India.
The coming.
Yeah.
I think now shall we go
Mamta?
for vote of thanks?
Mamta?
Thank you so
Just
much.
wanted to say thank you, Dr. Piali, for the wonderful talk.
Yeah.
Rekha
And
di.
I just heard my name. I was somewhere elsewhere. And I just wanted to inform the August gathering also that this was one of the criteria which was approved by the Central IAP also for the 10-point school accreditation plan for labeling any school as health. And it was unanimously approved. One of these points was that every child in the school should be trained for BLS by at least one teacher in the school being BLS trained. So it was a wonderful talk and very good revision of what we've been teaching our PGs for and our residents, and needs to be percolated down to the ground level to all on one and all, not only for doctors, not only for paramedics,
Yes.
but for everybody, because we never know when we can fall unconscious. It may be a sweeper standing by, it may be a gardener standing by. So it should be a public level, community level campaign, and can be taken up by women's group, women forum very well. Thank you so much, Dr. Piali. Wonderful talk.
Thank you,
Nice point,
Di.
Rekha madam.
Thank
so
you.
much,
Thank
ma'am.
you.
Thank you so much.
Asha madam was there. Asha Benekappa madam.
No, she's not. I think she's not here.
Okay.
Neither Elizabeth ma'am is here.
I shared my poem in the national group. Okay. Now, time for vote of thanks.
Thank you, ma'am. A warm good afternoon to everyone. And this wonderful session has enjoyable learning and knowledge. On behalf of Women Pediatrician Forum, I extend my sincere thanks to all who are attending this 83rd episode and have made this series a successful series. It's my privilege to propose a vote of thanks and acknowledge the contribution of our worthy speaker, Dr. Piyali Bhattacharya ma'am, for giving this wonderful talk. I would like to thank Dr. Ashrilekha Joshi ma'am for moderating this unique and useful topic of triaging and life support for children. I must mention a deep sense of appreciation to Dr. Hima Bindu ma'am, who is the founder chair of WPF, and Dr. Sangita Lodha ma'am, the chairperson and backbone of WPF. Ma'am, you are the biggest source of motivation and strength of pillar for our future endeavor. I extend a healthy word of thanks to Dr. Anuradha Sanada ma'am, Honorary Secretary of WPF, for her worthy contribution, and Dr. Elizabeth ma'am, Vice Chairman, who is always there to enlighten our path and encourage us. I would like to thank Dr. Narvada ma'am for her efforts and arrangements, and a sincere gratitude goes out to all participants for their active involvement in making this talk a memorable session for all of us. Thank you so much, everyone. Okay. Thank you, ma'am. Ma'am,
Bye. Bye.
A word of appreciation for Anuradha and for Srilekha. Thank you so much for being by my side. Thank you so much.
Wonderful,
Always my
wonderful,
Thank you for
wonderful,
thank you,
Piyali,
Piyali ma'am.
and